This is information for week 7, excuse me, looking at medical ethics across different cultures and different examples. A lot of the reading was actually provided in week 6. I wanted a chance for everyone to really grasp that reading before we got into this specific presentation slide. This presentation is probably going to be a little bit longer than some of the others. I really couldn't find a good place to break this into part 1 and part 2. But again, you can come back at any time to review the materials and look at it from that standpoint. So to begin with, medical ethics are really derived from the needs of a culture. And the ethics are interpreted and influenced by a number of different areas, be it religion, the folk beliefs, customs, even other cultures can have influence on another culture from that standpoint. And it may vary according to long-term needs. So we have some very short-term items we look at and items we do, but maybe trying to look long-term at ethics from a cultural standpoint to really understand that there are tremendous differences that we deal with. And when you think of the globalization of clinical research and clinical trials today, there are a number of items that we need to really take into consideration. And we'll talk about some of these throughout this presentation. To help try to emphasize, and again, the idea behind all these is that as you get more and more into these activities in your careers, that you take a step back and begin to think about it from an ethical standpoint. How can I look at this? How can I make sure that these are done the way we feel they should be? So culture is really a learned behavior, and it's characteristics of a group, and it includes that group's worldview. Now that worldview may only be a very small area, but that's how they view it. So the culture can be debated, but it really looks and is derived from, strangely enough, survival skills. And this is not peculiar to humans. Obviously, if we look at animals at all different levels, there are cultures and there are behaviors and there are, if you want to say, laws and regulations that they follow. They're not written, they can't read them, but we're very well aware of hierarchies that exist in different animals, how they do that, and everyone follows that culture. Everyone understands. You may challenge at times, but the culture is followed. And that is, again, not just specific to humans from that perspective. Some things that culture is not. Culture is not hardwired. So it's not like when you're born, you have culture and you've got it set and you're all done, everything else like that. It's not determined by biology. Culture is something that can be learned. Culture is something that you grasp. It's what is happening around you. It's the environment, different areas from that standpoint. And culture is not a collection of stereotypes. We've all heard things like this, all a specific type of group have this characteristics. Or did you ever notice people, these kinds of people, they're like this, and this. So culture is not based on stereotypes. Culture is truly broader than that. It's really how a group looks at things in a much broader view that we can take a look at. And so where does culture, derive from? It's a person's interaction with the natural and human environment. And as I said, that's why you're not hardwired for this. If you want to think of something that's hardwired, we think of some animals that at a certain time of the year will migrate a certain way. So that would be more of a hardwire for that, but we don't see that in humans per se from that standpoint. It's also, patterns in a sense, and patterns of interaction that provide the basis of how you derive different types of culture. And they can be taught, they can be learned. Culture is not something that you cannot pick up from someone else, that you cannot learn and understand someone else's culture. I think that's what's really interesting when we have globalization, is trying to understand how the practice and the methods and the protocols we establish for, if you want to call it Western-based environments, how do those apply to other environments? And how do we leverage that to really understand the culture, tailor the information to make sure it fits from that individual perspective? So how do ethics and culture kind of fit together? So for us to be a society, we have predictable interactions. You develop rules upon expectation. So as an example, and again, I think I've used this before in class, if we were sitting at a table together, would you expect me to share food with you? And the question is why? Different cultures look at food differently. And so we have to understand that and how we look at it. Do you expect all drivers to stop at a red light? Well, if the answer is yes, which I hope it is for everybody, that's a predictable interaction that we have in our society, that a red light would be a stop for a moving vehicle. We'll talk a little bit later that sometimes these cultural expectations become regulations or laws as well. So there are some universal ideas and things from an ethical perspective, and obviously a lot of this has come from, if you want to call it, the great religions. If you look historically across a number of areas, be it Judeo-Christian-based items, Muslim-based, Hindu, all the different types of areas and how we look at them. So the rules allow interaction and interactive relationships leading to society, which then has a number of items that it does. So you have reciprocity, you have ways to honor obligations, you have altruism called charity by some. Some religious groups and some cultures have different names for this. It's just their terminology that's used for it. There's differences when you look at family, procreation, sex, obedience, public order or public disorder, self-defense versus aggression, all these different things pull together in cultures. And they're different in cultures. And they should be different. We don't want to have everything be exactly the same. And that can be partially why some people move to different cultures or get involved with a different culture, because it fits them as an individual perhaps better than the culture that they grew up in. And as I just mentioned a few minutes ago, we can at times see how these become an expected behavior, and then they are actually formalized into a law, such as red light, you stop. Much of law is really a restatement of the ethics. The difference is there's some kind of a punishment or something else that's there if you're not following it. However, you need to review the laws over time, as culture can change. And we'll talk about this in a little while as well, but bottom line, you are all well aware of the fact that when you take a look at the laws, and I'm just going to use North Carolina as an example since we're based here for the program, there are many laws still on the books that are from the 1800s that do not apply at all to current culture. And so they really need to be reviewed. They need to be, in a sense, removed, or new laws put in place that are better fits for the culture of today in society. So there's also cultural influences, and let's use something that we use in clinical research as an example, or a clinical trial for pain. We're asking a patient to give us a scale of 1 to 10, 1 little or no pain, 10 the most severe pain they've ever had. And so the question is, someone who's not literate or a nonlinear society, do they even understand this, and what does it mean? So the question comes up from an ethical standpoint: is it really appropriate way to determine how much pain a person has to then determine the medication to give someone if they don't understand the pain scale? So, is an 8 from one person the same as an 8 from someone else? And in fact, researchers would say from a quantitative standpoint, they have a pretty good feel what that means. But from a qualitative standpoint, that's where this kind of has the ethical side. Numbers tell you, well, if we're saying 10 is the most severe and one's not at all, then you are able to determine what's in between. It depends on someone's pain threshold. It depends on a lot of other items. Some people in their cultures don't talk about pain. So if someone asks them, do they have pain, they're going to minimize it as much as they can. Other cultures may talk about pain, and that you have a little bit of pain, you say it's really bad. So we have to be able to, again, look at the culture when we're asking these kind of questions. And we also look at something called comparative law. You can take a look at a culture's ethical beliefs by what their laws are. And what do their laws say they can do, and what do the laws say they cannot do, so to speak. And what are the consequences that they have for those laws? And these, again, change over time. We still have issues in the U.S., and in the statements I'm making, I'm not saying one side's better than the other at all. We have some states that have death penalty and some states that don't. Is one better than the other? Is it based on the culture or the environment of that state and the people of the state and how they feel about a specific area? And so you begin to start thinking, well, how can it be that different? When in fact it is, because culture as a whole, as we say about healthcare and medicine, is local. There are different cultures across the United States. There's different cultures even within neighborhoods of cities. So we take a look at many of those to see how things are going from that perspective. So let me give you some examples. If we were talking about this 15 years ago and mentioned medical marijuana or mentioned medical heroin, people would be up in arms. Whereas today, the culture has shifted, especially for medical marijuana, where we have a number of states that now allow and actually have, in a sense, approved medical marijuana. It can be purchased at specific stores or things of that nature. Medical heroin's a whole different question. But again, if we're talking about someone who has terminal cancer pain, how do we measure this as a clinical trial to determine how we can help that patient? So there's a lot of items to look at. And again, the question from a clinical trial standpoint is how do you measure scientifically cancer pain? Is pancreatic pain different than bone cancer pain? It's a tough question to ask. And to me, this is an ethical question. Is pain the same for every disease state? I would say probably not. All of us have dealt with different levels of pain. I can give you what I say is my worst pain that I ever had was actually eye pain when I had a scratched cornea and a nerve was hit. It put me right down on the floor. I couldn't even stand up. I was in so much pain. At the same time, I've had the great fortune, so to speak, of having the issue with kidney stones. And fortunately, there's treatment for that today that helps alleviate that. But if you were going to ask me, I would say the eye pain was the absolute worst thing I've ever had in my life. Now, that to me is a 10, and it's going to be hard for anything to reach that. So it's one of those items that we have to take a look at the experience of the individual based on their culture and how they're going to respond to that kind of question. There's also a lot of competing values. So there are social values, or sometimes known as social norms, may compete for things within a culture. So, today we do have some drug-free societies where there's not a legal addiction. It is, in a sense, legal. And how's the crime related to that and accidents and things like that? We talk about value of the quality of life. Do we include, the right to relief from pain and disease? And what do we mean by quality? And while we do have specific types of quality of life measures, such as you guys are probably familiar with the short form 36 or some of the other newer ones that are out there, there's still quantitative measures for the most part. They're designed off of qualitative research, but they're quantitative measures put to a number. And that's always difficult for me because I'm a qualitative researcher, to put numbers on those types of items. So we have competing values, and then we have changing ethics. And as you mentioned before, this can happen based upon a shift in the opinion of the culture itself, just a complete shift, change in education, technological advancement where people learn things faster, get access faster, that can change the value that's there. But a lot of this is really based on resources. And resources in a different perspective, perhaps, than you may be thinking. So let me give you an example. Circumpolar society. So we're talking about those that live near the North Pole. Let's put it this way: very cold environment. A lot of cultural items that are there, and it's interesting that the elderly, to kind of ease the demands of the family, that once they get to a certain age, and once they see that they're really not able to provide any support or any additional value to the family, that they'll just go for a walk, and they just wander off in the cold, and that's it. It's very interesting to think of things from that perspective, but that's a culture, and that's how that culture has developed over time, and how they look at that. And that can lead to some different, problems. So cultures can disagree on issues regarding early life and late life. We'll talk a little bit about some of the early life and late life issues, but we also have marginal individuals, and these individuals have little to no power. They don't fit within the culture, and they don't necessarily know how to get to different areas. And at times they are fine being marginal individuals, but many times they're not, but they just don't know how to make the change. The other side of the problems that we deal with from a culture standpoint, and from, again, this globalization, is looking at lifelong issues of autonomy. And this is really an issue for clinical research. Again, from our standpoint, autonomy is the opportunity to, as a participant patient, to withdraw at any time. I have autonomy to make decisions about my own body, about what's happening, about my volunteering, about the study. Give me the information. I need to be informed. I need to consent, and going through that process. And just to touch on a couple issues, and again, as I said earlier, not saying one side versus the other, abortion and popular ethics. We see this quite a bit. Eric Rudolph has written some things about this. Regulating emotional latent functions does not exist in a vacuum. You can't just look at one item in a silo and that's it. It's really the values of participating parties, and the parties can differ in beliefs and ethics on the same issue, and that's obviously something we have here. And this is where some discussions from an ethical standpoint are, do you save the life of the mother? For the health of the mother, how do we do things? What are the economics of this? Ethical considerations. There's just a whole variety of things that go with this. And again, if you think about the idea of a culture, you can have people within a culture who have different viewpoints in this type of an area. Now we can look at infants, and most people don't necessarily think much about this from a different perspectives, but as an example, there are many cultures that will not name an infant until a certain age. So as an example, there are cultures in Africa that there's a high percentage of births do not live past age 5. So they will not name their kids until they reach the age of 5. There's no name, nothing affiliated with the child until that time frame. And the reason being is they don't want to have that additional concern, so to speak. Not that a name makes anything different, but culturally, that is something that has happened. And in different religions, you have different naming type ceremonies and items that happen, for infants and things of that nature. So there's different items that come from a culture that perhaps some people, again, don't think of broadly, but can definitely be there. And the one that's really probably most often talked about culturally is elderly. I mentioned before about those who may live, in the North Pole and some of the issues that have happened there with elderly. Um, and, that's in the example I provided where the definition here and the information here talks about moving from producer to consumer of resources so that you're not being a productive member of society. There's some folklore roles that, may diminish the role of the elderly, and no doubt prone to more illness, and to more serious illness, and may require attention of others to really help take care of them. Whereas when people are younger, they can take care of themselves or have one person that they're with, or other family members that can help that way. But it's not normally looked at it as with elderly, which is a long-term chronic type condition. So again, in elderly, we see an increase in different disease states, from, different types of arthritis, rheumatoid or osteoarthritis, congestive heart failure, and the others that are listed here. All of these things affect the participation in the group survival. So think of the culture, think of it as a group, and how you may look at it differently. And this is how people deal with it from a different perspective in different cultures. So you look at things such as, death with dignity. And Osler had come up with the idea of saying that pneumonia is the old man's friend, because as you're old and you're not able to do things and everything else, you have pneumonia, and that kind of ends your life. But since then, we've been able to do things. We have found ways to treat pneumonia. We have, TPN and antibiotics and, ventilator support and all the different things. So the question when you look at this from an ethical standpoint and a cultural standpoint is, did we change or did technology change? So we don't talk about pneumonia as being an old man's friend anymore. We now talk about pneumonia as the old man's enemy. You don't want to have that. So it's an interesting change in the culture and how we have dealt with it from that standpoint. But this is something we talk about quite a bit in, again, I would say, the United States and some of the other, lack of a better term, Western culture type of areas. In most cultures and societies don't even have these types of discussions. The culture is set. We know how it happens. People take care of others, whatever it may be. Some religions have certain ways that they do things, whatever it may be. But a question that I bring up to you as you're thinking about this is, what are the ethics of a patient who has a do not resuscitate, statement? Can this be overruled by any family member? So, let's say a person has a do not resuscitate and they're in the hospital, and I'll use a personal example of a mother who has told kids that I do not want to be maintained by machinery. I don't want to be maintained by a ventilator and by other things. If I'm not able to do this on my own, just let me go. And that's the wish of the person and the wish of the DNR. But you may have one of the children who disagree with that and who feel that by able to maintaining the person, that there may be a discovery 3 days from now, 3 months from now, 3 years from now. But there are reasons why cultures accept DNR. And if the person who provides this is in a good frame of mind and able to go through all that, that should be honored just as much as we do in clinical research, where we say when a patient says no, it means no. They don't want to participate. I want to withdraw from the study. You can withdraw from the study. Again, culturally, this is much more difficult, but it does tie in to those kinds of items. And to shift a little bit and talk about some things that were in JAMA. Now, this is from a few years ago, But again, sometimes some of these older items I think are interesting to look at. Ethics and legal analysis of medical decision making in the United States really has revolved around the idea of patient autonomy. This was written back in 1995. I'm not sure that holds as much today as our culture has shifted. And we take a look at resources, we take a look at different healthcare alternatives, health plans, a variety of ways of trying to look at different areas. And the patient autonomy may not be there as much as we would like it to be anymore. It's just something that I really think we need to review and take a look at. In clinical research, I think we do much better than looking at this from a cultural standpoint. Again, the autonomy is that when the individual says yes or no, we're letting them make the decision. The patient has the autonomy to make that decision. And as is in the second bullet here, that the patient has autonomy to assist the right of the individual to make informed decisions. And underlying individual there, because it is the individual choice. So with that being said, if you think about cultures and think about ethics, should patients be told the truth regarding diagnosis? Should they be told the truth regarding risk and benefits of a treatment? Should they be allowed to make choices based on this information? Well, the answer is, from our standpoint in clinical research, yes, they should be provided as much information as possible at the level that they can understand the information, be able to provide back to whoever is doing the work with them in order to make an informed decision. But we do run into some issues. They need to be able to understand a variety of items, and these are the same two items that were on the other slide. I apologize, I realized I put them on here again from that standpoint, but again, understanding individuals, looking at it from that standpoint. So there have been some studies in different cultures, and there are 4 cultures that are represented here. And this is done through the United States. And you look at Korean Americans, Mexican Americans, African Americans, and European Americans. And they were asked, should a patient with metastatic cancer be told that they have the disease state? And it's interesting to look at the percentages that say yes. And I'll let you make decisions on how you feel this goes, but this is culturally based. This is the culture that these groups have grown up with and brought with them and have today. So it becomes very interesting in trying to understand this. So think about it from a healthcare practitioner standpoint, the PI of a clinical trial and what they're trying to do. Let's say it is a clinical trial looking at metastatic cancer, and we've got a new treatment we're trying to provide. Families are there to help make decisions. Depending which group they fall into, they may not want the person to know, but in fact, we need to let the person know. So we may be going against our culture a little bit, so we have to be able to explain that, and understanding that you really prefer not to have the person know. However, for us to do our research, for us to be able to look at the risks and benefits, they need to know. This is another interesting item. It is, in a terminal illness, should the patient make the decision regarding life support? Again, talking about DNR. Again, look at the differences that are here. Percentages a little lower in cases here. However, this is where you look and say, okay, culturally, what they're really looking at is saying that the society may have more of a say than the individual. So you have to kind of look at that and get a feel for how that goes. There are different autonomy models that are out there. Physicians and patients to engage in therapeutic decisions. There's family-centered models that allows the entire family to be involved in the whole item, including the diagnosis and prognosis, and that really gets worked through the family, and then the family provides the information back to the patient. Again, one is not necessarily better than the other. They're just different models of understanding how different cultures and different groups prefer to work through these decisions. And lastly, there's a question at end of life that is different. And so this is the other end of life, looking at contraceptive services and STD treatments and abortion. And again, just to have you think about it from a standpoint of how you want to look at it. Now, the last few slides on this section, I had the opportunity a number of years ago to work with Dr. Warren Anderson, military. He a physician who oversaw a number of different areas. And we talked about the ethics issues. So he was stationed over in Iraq with the Ministry of Health Facilities and had oversight of the protective services officers. So these are the United States and the Iraqi trained officers that are really there to help the Minister of Health Facilities to make sure that they can be open, they can run, and really, serve the population that is there. And the problems that he described were kind of broad. Some are very easy to answer. And so as the security person or whoever you may be within that facility, you know what to do and how you can handle it, and others are much more complex and hard to do. So you may need help from friends or colleagues, but you have to be careful because in that environment, you have to be able to understand culturally who wants to hear what. And so you have to be careful in how you go through it. So he provided 3 interesting situations to take a look at from that standpoint. Number 1, so a friend tells you that he needs a special medication because his child has an earache, but he cannot afford to see a doctor. And from an ethical standpoint, there's a number of items that these security, but also people who are trying to help maintain the health and get people access to things they have is, a couple options here. You can, talk to your supervisor to see if they can do something to help from that standpoint. You can give your friend the money that he needs. You have to be careful culturally if that's considered to be a reasonable thing to do. In some cultures, that'd be fine. In other cultures, that would be really frowned upon. You can take the medication at night when no one is will worry about it, or give the medicine you have at home that could be used for that. And it may sound like, well, geez, it's easy to make this decision, but when you're in an area, again, so you have the U.S. in Iraq in a military situation where they're trying to help maintain the health ministry and providing services to the people of Iraq, you can run into these kind of dilemmas. Someone tells you they're going to rob the hospital and you better be sick at home. So here's options that the person may have. And culturally, it depends on what they think is the best thing to do. Again, I'm not saying 1, 2, 3, 4 is an order or anything like that. Just these are the ways that he provided information to us in saying that these are the issues ethically that people had to face on a regular basis. And it became very hard to try to help them understand what is the best thing to do, because culturally it may have been, I'll get sick at home then if that's what you told me, because I don't want to interfere with what you're going to do. A protective officer is taking a narcotic drug from the pharmacy, tells you not to tell anyone. And here's the option: say, well, okay, last time, otherwise I'll tell somebody, talk to your supervisor, help him carry the drugs to his car. these may seem kind of crazy, but again, in the environment that Dr. Anderson was talking about, these were items that happened every day, and very hard decisions for those in the protective services to try to help or not help in those areas. So I'll leave you with that. I thank you again for listening through. Again, I know this one was a little bit longer, but hopefully it did pose a few questions that you will ponder as you continue to work through different aspects of your career. Hope you have a great evening.